Okay, so I am going to turn it over to Dr. Peterson to introduce our topic and our speakers.
Wonderful. Thank you, Elizabeth. I'm really excited about our presentation today. This is something that I have been wanting to do for a while, and I'm so glad we have such a really excellent panel of speakers today. I'm thrilled with everybody that's joined us. First, we have Dr. James Bailey. After that, we have Dr. Deborah Gore. And last but definitely not least, we have Austin Moss, who is a community member ready to share their experiences receiving health care in our community. So first on the agenda, we have Dr. James Bailey. His pronouns are he, him, and he is a primary care physician in Post Falls, Idaho. He received his medical degree from University of Michigan and did his family medicine residency here in Coeur d'Alene at Kootenai. I believe he might have been one of our first graduating class. He's trained in comprehensive primary care and has a particular interest and expertise in mental and behavioral health, in transgender medicine, and in preventive health. And he has 3 children, Felix, Birdie, and Connor, and a wife named Erin, who is very supportive, and he's grateful for his family. So without further ado, here is Dr. Bailey.
Thank you, Emily and Elizabeth. Everybody can hear me okay? Thumbs up?
Yep.
Okay, perfect. Great. Well, hello, everybody. So I'm going to give kind of an introductory overview to the basics of what transgender even is, and kind of a really high-level overview of some of the medical processes of transitioning, medical and non-medical processes of transitioning. This is a simple introductory lecture. We could do a whole lecture series on this. So if you're listening and thinking I've oversimplified or glossed over something, you're probably right. But this is enough to get everybody on the same page. So basically, we need to be able to, I'm going to help you be able to communicate effectively to other people and to your trans patients, to other healthcare providers and to trans patients. And the best way to start is to separate in our minds sex from gender, the word sex from the word gender. Those are used synonymously in a lot of culture and historically, but we need to be accurate in medical communication because, I mean, the easiest example would be that the differential diagnosis for a cisgendered man with abdominal pain is very different from a transgendered man who may have ovaries and a uterus if they have abdominal pain. So we need to be able to communicate clearly. And so think of sex as the physical state that is generally assigned at birth and or on a prenatal ultrasound. And you've got male on one side and female on the other. And I'm glossing over disorders of sexual development. There are more options than, you know, for sex than male and female, but we're not going to go into that right now. So it's generally thought of as binary. So that's the physical. And then gender is an identity, and there's multiple components to it. There is outward expression, you know, which is largely to do with cultural norms and fluid over time. Not that long ago, it was exclusively masculine to wear pants, and that's something that's changed. There are societal gender roles, which also are more fluid and change over time. And then there's the internal gender identity, which may be something that some people haven't ever even considered, because if their sex and their gender and their role in life all kind of line up, maybe they've never even given much thought to what their actual identity is internally, what they feel like, what feels right to them. But that's the gender identity that we're talking about. So gender is an identity, sex is a physical outward characteristic, to put it simply. So if you think of it as 2 separate lines or scales, male on one end, female on the other, you've got your sex, and then gender with male on one end and female on the other. If a given individual's 2 scales line up so that they're on the same end on both scales, they're referred to as cisgender. And if they're on opposite sides of the scales, sex on one end, gender on the other, they're referred to as transgender. Cis and trans are just Latin roots. It's the same words we use in chemistry. And so you would have, if you had someone who has a male sex and a male gender identity, you could call them a cis male. And if you had somebody who had a female sex, assigned female at birth, and a male gender identity, you could call them a trans male. And that's the basics of the nomenclature. To make it a little more complicated, I briefly allude to that sex is not necessarily binary because there's some issues there. Gender is definitely not only binary. So it's not just trans male or trans female. It's somewhere on that line in between the two ends. And so a more accurate term, rather than saying like trans male, would be, or a more inclusive term would be, say, trans masculine or trans feminine, because that implies that somebody's on, the other side of that spectrum from maybe where their sex was assigned at birth. Or some people don't want to pin down to a specific spot on that scale, or they're somewhere closer to the middle and might just identify as non-binary or somewhere on the gender spectrum. This is where we could get really bogged down in vocabulary, and vocabulary is important, and we'll talk a little more about it later in the talk. Some of the other speakers will, but that gives you just the basic understandings. We're all on the same page of the differences between sex and gender, physical attributes and identity, and trans feminine versus trans masculine versus non-binary. And if you don't know how to refer to somebody, or that seems confusing, or you mess up and you commit a faux pas, the most important thing is to remember that, we're all humans, we all make mistakes, and your intent and your sincerity is what matters the most. So if you do accidentally misgender somebody, or you need to ask them, how they want to be referred to, or how they identify, that's fine. And if you put your foot in your mouth, just apologize and let them know that you are sincerely trying to be inclusive. And I think most people will realize that. It's like if you're talking to a patient with a name from a different culture with different pronunciation rules, and you mispronounce their name, they correct you, you do your best to correct and call them as they're called, and everybody moves on. If you were to decide to intentionally mispronounce their name because for some reason you don't want to respect their name and their identity, then you're being a jerk and you shouldn't do that. But it's just like everything else in medicine, and we have a lot of conversations, and I've certainly put my foot in my mouth on a whole bunch of things in medicine, and we learn how to get through it. So that's the basics of kind of the transgender nomenclature. So now that you understand the difference between sex and gender, what do we do when those two things are not lining up? Well, potentially, if an individual is happy, you don't need to do anything. But a lot of times when the sex and the gender don't line up, that causes dysphoria, depression, unhappiness. And so the solution is to bring those things a little more in line. So that's what we call transitioning. There's all sorts of transitioning. There's entirely non-medical things. People can transition their fashion, their mannerisms, their appearance, their roles in society, their pronouns, their names. All these things that we tend to attribute as this is feminine or this is masculine. People can make those changes in their outward expression and role in the world. And so that's one step or one part of transitioning. And for some people, that's the extent of their transitioning, if that's what feels right to them. There are more biological or physical transitions that is where the medical community comes in. And those are kind of broadly divided into hormonal treatments and surgical treatments. Very simply, because I know we're not all, prescribers, and it would take a whole different lecture on how to do the actual nitty-gritty of the medicine. But if somebody is trans masculine, they're usually, and they choose to do a hormonal transition, they're usually treated with testosterone. And then that induces changes in the body like deepening of voice, increased body hair, beard growth, potentially, baldness, if that's what's in their genetics. Increased height, typically if their growth plates aren't totally closed at the time that they start testosterone. If somebody's trans feminine, they're usually treated with some sort of estradiol and usually a testosterone blocker. Not always, but usually. And then that causes decreased body and facial hair, and it can cause breast development. And what age somebody is when they start that and how far out of puberty or into it, can determine kind of what the end results are. And there's some monitoring that goes with it. There's like every single medication out there, some risks and benefits. It's not exceptionally complicated. It's well within the wheelhouse of primary care. It's on par with lots of stuff that we treat in terms of medical complexity. And then there are surgical options, which we kind of broadly divide into top surgery and bottom surgery, whether it's just in the top half of the body or the bottom half of the body. And options that exist out there for trans masculine people might be top surgeries involving mastectomies, bottom surgeries involving genital reconstruction, and there's a bunch of different surgical approaches. For trans feminine individuals, could be breast implants for top surgery, could be genital reconstruction for bottom surgery, and then there's other surgeries, like Adam's apple shaving or other kind of feminizing or masculinizing procedures that fall into that. It's important to understand that there is not like the right path where you start this and you do all these things in sequence and then you've transitioned. It's individualized. Some people get surgery, some people don't. Maybe some people get top surgery, some people only get bottom surgery. There's different options for all of those. Maybe they do hormones, maybe not. It's individualized medicine like every part of medicine should be. But those are kind of, very broadly speaking, the options that are out there for medical transitioning in addition to the more societal and expressive transitioning. And then I'm going to stop there. I could go on for the whole rest of the lecture, but we've got lots of other good stuff. So if you have any questions about that, we'll circle back to it at the end.
Thank you so much, Dr. Bailey. That was fantastic. I just want to remind everybody that if you have questions for Dr. Bailey or any of our other speakers, please enter them in the chat, and we will have some time at the end of the program where we can address all of your questions with the appropriate speaker. So I will keep track of all of those. And again, thank you so much for joining us today, and that was wonderful. Next up, we have Dr. Deborah Gore. Dr. Gore is a board-certified family medicine physician for Kaiser Permanente. Her pronouns are she, her. She works in Spokane, Washington. She received her medical degree from University of New Mexico School of Medicine and has been in practice for more than 20 years. So I'm running behind her right now. In addition, Dr. Gore is a part-time clinical faculty member at the University of Washington School of Medicine in Spokane. And Dr. Gore founded the Eastern Washington Gender Health Group, a group of providers, therapists, social workers, and others who care for the transgender community. She's very prominent, and we are thrilled that she could join us today. Thank you, Dr. Gore.
Thanks for having me. I really appreciate this opportunity, and it's really a pleasure to hear Dr. Bailey talk. I had the opportunity to work with him when he was a resident, so it's really exciting to see that he's off in the world making such a great name and impression on everyone. So thanks, James, for setting me up. When I was asked to speak here today, the instruction was talk about whatever you want. And so that's pretty broad. So I did go ahead and pick a couple of things with the intent that I was hoping to set everyone up to be successful in working with the LGBT, and in this case, more specifically, maybe the transgender or gender health community, knowing that I'm speaking to a pretty broad audience. And so I kind of broke it down into a couple different categories. So just bear with me. And please, yes, if there's any questions, I'm more than happy to answer. I come with about 10 years of experience in treating patients in the gender health arena. And a lot of it has just been by my own interest and learning as I went along the way. One of the things when it comes to considerations for, in this case, I would address all of sort of general staff and really the public, friends and allies of trans patients. I think when I think about the things that are really the most important when I've queried patients over the years, the thing that is often distilled when I say, what can we do as providers to help you? What I hear back is, call me by the name I want to be called, and please use the pronouns that I choose. And so if there was nothing else that you take away from today than just that, then I would say you're going to be successful. In addition, when it comes to creating safe spaces for patients, I think just like we would do with others, but even more so with our LGBT friends, making our clinics available and welcoming to them, putting up signage that says, you know, you're going to be not safe. But just for example, now that it's Pride Month, I know that I have signs on some of my doors that say, you know, all are welcome here with a rainbow flag, to just sort of identify that this is a safe space. I think also wearing pins or badges to identify yourself, that you're someone that they can trust and that they can feel safe with, is also really important. One of the other things that was mentioned early on for us here at I work at Kaiser Permanente here in Washington, was making sure that all of our forms are updated. So our intake forms when patients come in, for example, when asked about gender, that they have the option to identify that there's room there to identify to the gender that they identify with. So not just making it male or female in that case. So those are just some basic things that I think everyone can attend to and pay attention to. And it doesn't seem like a lot, but again, after 10 years, what I've learned is it actually does really matter. To be called the name that you choose, to be referred to with the pronouns that you choose and feel comfortable with, is just, I can't say enough about that. With regards to providers, I wanted to sort of single any providers who are out there on this call, because I get asked a lot, what are some things that you can do or that we can do as providers? And so I just kind of came up with a list of things that I'll share, again, over my years of experience. The first thing is just being really open-minded and willing to learn. When I first started doing this work, I really didn't know anything, and I had to reach out and talk to a lot of people. And unfortunately, at the time, I had to lean on a lot of my patients to educate me. I think that's changed a lot. There's a lot more information out there. There are CME opportunities. There's people like myself and Dr. Bailey that you can refer to and call on for questions. But just having that willingness to learn, I think, is very, very valuable. I think we have to be careful as physicians not to make a lot of assumptions, that if you have questions or don't know when dealing with patients, definitely better to ask, of course, in a non-judgmental manner, even if it might feel uncomfortable, but just better not to make assumptions. So for example, I think of the question of sexual identity, because oftentimes we don't know, and it may not be as obvious as it seems. And so asking those questions before making assumptions. One thing, as I've spoken, over the years, I've had the opportunity to speak to medical residents and students and even my colleagues here in Washington. And one of the things I think that's really important for us as providers to really kind of keep an eye on is our own curiosity. And I've had transgender patients in the past tell me that they had exams or comments were made or looks given to them in emergency room settings or even clinic settings that weren't necessarily appropriate. And so I think just keeping an awareness of our own curiosity and curbing that we don't necessarily need to do physical exams on patients if it's not warranted. Another thing I think that's important to take into consideration is that we all make mistakes. And, you know, I might actually reference a patient by the wrong pronoun or even the wrong name, for example. And if they correct me, to just correct the mistake in the moment. I think apologizing and being as authentic as we can is really important and carries a lot of weight, especially just in terms of building relationship with patients. One of the things I tell my students a lot is that it's really important to manage expectations right out of the gate, letting patients know what I know, what I don't know, what they can be, what they can expect in terms of treatment. For example, if I'm prescribing hormones to a patient, or if I plan to, I never do it at the first visit, and I know that right up front so that they're aware of, again, what they can expect. I think it's always really important to train your staff. One of the things that I've done here at Kaiser, and we've worked really hard on, is making sure that everyone from the patient representatives where patients check in, to my medical assistants, to the nurses, to even my colleagues, that everyone has some understanding. So again, that if I'm trying to create this safe space for these patients, that they are going to have that experience right from the time that they enter the building. Because they're going to meet 2 or 3 or 4 other people before they ever get in to see me. And I want to make sure that they're really comfortable. So every 6 months or so, I do a training of the staff here just so that they have an opportunity to ask questions or make sure, because there's always lots of new people coming in. And then again, just having a lot of empathy. As providers, that's such an important part of our job anyway. But really recognizing that for a lot of these patients, there have been a lot of hurdles and obstacles sometimes for them to get in, even just to walk in the doors of the clinic. And so to recognize that and know that, and a lot of them have had also stories of either a lot of judgment in previous medical care, or just not such great experiences in the with healthcare providers. So trying to be as empathetic as possible, I think, really makes a big difference. So that's number two. Those were kind of the two main first categories. The third category, again, because I was given sort of a free rein, that I just want to mention, and this is something for everyone, is that when I first started doing this work, it was very clear to me, and I think Dr. Bailey mentioned this a little bit too, that there's sort of this spectrum of care, or the spectrum of gender when we talk about it. There's sort of the male on one side and the female on the other. And early on in my professional career, it was very clear patients were coming to see me because they wanted to transition from one to another. And it was very binary, as we call that. But over the years, I've really come to appreciate, and thanks to my patients, really, that there is this very middle ground. And I think it's really important, and I want to really emphasize the demographics of the non-binary patient. And I think that can be really confusing for a lot of people, be it providers or staff or family members, allies, and what it means to be non-binary. And I'm not sure I would, in this short time period, be able to go through all of that, but I just want to give it some attention and sort of highlight that non-binary patients are there. They are, their existence is really important. And I think, again, as providers and allies, it's very important that we recognize them. So I would encourage you all to educate yourself and to be as authentic as you can when encountering patients who are non-binary. Again, using the name that they prefer and pronouns is very important. I think patients, or I'm sorry, not patients, but people in general, be them healthcare or even out in the general public, are very confused when patients or people say they use the pronouns, for example, they, them. And I've had to answer that question many times. Well, what does that mean, they, them? That's not really a pronoun. That's multiple people, not just one. But again, I think we have to educate ourselves and gain confidence and just a familiarity, because patients, that's what they're comfortable with. And then it's up to us to really respect that. And finally, just for one little shout out, my final point that I want to bring about, and I know it can be a little bit controversial, but in this day and age, I think it is really important just to mention it. But that is to say, the topic is trans youth. And I would say years ago, the numbers of patients I saw that were under the age of 18 were pretty minimal, but that has definitely changed in the last, say, 3 to 4 years. And again, just to sort of acknowledge the existence, and that, again, as providers, it's really important for us to educate ourselves in how we handle and manage these patients, that in doing so, I can't emphasize enough the importance of bringing parents along into that process. And if you have questions as a provider and you are uncomfortable, again, there are lots and lots of resources for us out there these days. And finally, I guess I would just say that validating a young person's experience, no matter where they are in their lives or on the spectrum, is probably the most important thing. And these young people, as well as adults who are on this journey, often suffer with pretty significant mental health issues, and we know more and more of the reality of that. And so, I think not dismissing people, but really validating where they're coming from, and just, as we're trained to do, doing the best that we can. So I would also, the final thing I would just like to say is that whenever we're dealing with this population of patients, I think we will be the most successful is if we can come at it from a team approach. And, I work together with a nurse and a medical assistant and a social worker, and we have this really great team that works well together, because we know that there are a lot of resources that often are needed in the care of these patients. So as much as possible, if we can work in that dynamic, I think it's very helpful. So those are the few things I wanted to mention. I'm happy to field questions all along the way. And really, this just comes from years of experience to kind of help augment what James, his much more practical, probably relatable information was. But thank you for your time.
Dr. Gore, that was fantastic. Thank you so much for agreeing to participate and providing your wisdom. We really greatly appreciate it. And I heard a great story. Actually, Austin probably can comment on this a lot better than I can, but since I have the microphone now, I'm talking. So I heard a great story probably a week or two ago about you know, people having concern that they, them is a group pronoun and not an individual pronoun. And the person said, well, what would you say if you were walking into a room and needed to tell the whole group that one individual had left their lights on their car? You would say someone left their lights on their car. And that's referring to an individual person. That's grammar. It's appropriate, correct grammar referring to one individual person. It's something that's historically been used in the English language for ever since it was developed. So it is correct grammar. So I thought that was a good story and a good reference to provide if people do have that concern that it's not correct grammar. Anyway, so moving along, we have, I'm very, very grateful to invite Austin Moss to speak next. I work with Austin on the board of the North Idaho Pride Alliance, and they are a member of the board as well. They studied at the University of Idaho and work as a behavioral health technician. They have experience as a transgender, non-binary community member seeking healthcare in the local area, and they will be sharing their experience and recommendations for creating an improved patient experience. And I really feel like these community member, this community member representation in this lecture series is probably the most important aspect. It really gives us a personal sense of the experience that people go through in this area and an understanding of why we need this education. And so I am incredibly grateful to have you here, and we'll turn the microphone over to you now. Thank you.
Amazing. Well, thank you so much. I really appreciate the invite to speak today. Also, thank you so much, Dr. Bailey and Dr. Gore, for everything you've shared so far. It's super encouraging to see folks with expertise in this area and also invested in sharing that expertise. So yeah, very happy to be here. I guess so today I'm going to talk a little bit about my experience as a non-binary trans patient and share some like experiences I've had in that patient experience, but also share maybe some insights as to like how we can promote a more gentle and generous experience for trans folks, because yeah, I feel like the trans experience, especially in places like Idaho, in healthcare, is one that generates a lot of fear for trans patients and a lot of distrust. So yeah, thanks everybody for being here. Also, I love what you were sharing about the they them pronouns. I always use the example when I'm explaining that, like if you were at the grocery store and you saw that a wallet had been dropped on the ground, you would say like, oh, somebody dropped their wallet. I hope they can find it. Or like, I will take it to the front desk to help them locate it better, you know. So the singular use of the they them pronoun is absolutely grammatical. Yeah, I really appreciate it because they're my pronouns as well. And then, yeah, Dr. Gore and Dr. Bailey, I will also like really elevate that. I appreciate the interrogation you've done of more nuanced identities that aren't just binary transition. I think that is one of the areas that creates the most distrust or difficulty for trans people in Idaho. At least that's what I heard when I started looking for trans healthcare here in the state, is that I, as a non-binary femme person, should lie to my doctor, because um, previous folks had experienced being dismissed or denied care because they had a non-binary identity, as opposed to walking in and saying very confidently, I am a trans man or I am a trans woman. So I really appreciate that interrogation of those identities that exist somewhere on that spectrum, as opposed to a binary, because yeah, that's probably one of the first places I would start, is to kind of trouble the impulse to live in a binary system. So but yes, in the way of like experiences, I can share. I would just say that the biggest thing for um, making sure that trans people are more comfortable, and some of this is going to rehash what has already been said, but um, really training front desk staff, really changing paperwork, changing all aspects of the new patient experience so that they are more inclusive. Because I feel like promoting increased transparency around all decision making, it can only build a better trusting relationship with patients. So things that might be standard practice might not appear as such to somebody who lives in a system that makes them feel insecure for whatever reason. So basically, what I mean by that is if there's like standard mental health screenings that you have to do for all incoming patients, explaining that to the patient and saying like, we do this with everyone. We'll have you do this screening. Or if you have basically a standard practice of having folks wait a certain amount of time before prescribing them, explaining that, because if you have a trans person who's already overcome so many obstacles to finally land in your office or in your clinic, and they're probably under a lot of stress, and then the first thing you say is like, well, we're going to have you wait. They've probably been waiting a long time already, and they might perceive that as like, well, you might change your mind, right? You might change your mind. You might decide that you're not actually trans, because that's also the socialized message that's being received. So if you explain like, I just want more time to develop a better rapport with you and make sure blah, 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 whatever that is, having increased transparency around like why you have patients wait before you give them a script, is helpful. I've also had the experience, yeah, like with front desk staff, outdated paperwork that asks for binary gender things. I've been misgendered by, I've been misgendered by front desk staff literally like 2 minutes after I gave them my pronouns and everything. So that's always frustrating, and it increases the amount of distrust that a trans patient is feeling, because I feel like a lot of trans people, especially in Idaho, enter the space thinking like, oh, these folks aren't competent and I'm going to have to do a lot of educating, and then when the first faces they're greeted with are greeting them with what could be considered to some as microaggressions, it doesn't give a big vote of confidence. So yeah, so normalizing pronoun usage, whether that's in a meeting, adding your pronouns to your name like mine is on the screen, with virtual meetings, normalizing sharing pronouns in your co-working space. Also, because not all of the trans people that you encounter in medical care are patients. Many trans people are entering healthcare as practitioners. So, it's just as important to normalize that practice for your coworkers as it is for your patients. So that's huge. Yeah, explaining the wait times for any prescriptions. I also think a lot of trans people um, would benefit from an understanding that like we remain trans in other medical interventions. So like if I was to go in for another procedure of some kind, like I'm still a trans person and want to be treated as such. And if we have increased confidence that I will still be treated as a trans person, I'm more likely to engage in more regular care and screening that is preventative and important. We know that trans people are more likely to experience chronic illness because of either mistreatment or putting off accessing medical care for whatever reason, whether that be access to resources not being present, not having health insurance for whatever reason, or not trusting the medical system that they live near. So, so yeah, we want more trust. We want more confidence in our medical systems that they are competent and that the practitioners there are not going to unintentionally harm us in some way. Yeah, I think especially with yeah, pronoun usage is a thing. Mental health screenings are a thing because the assumption is that, like, you know, gender dysphoria is still in the DSM, and a lot of queer identities have in recent history been seen as mental disorders as opposed to identities or ways of orienting to the world. And so increasing the transparency that we have around like what decisions are being made about what medications, if there are any medications, what medical procedures, basically anything like that. Yeah, I've also had the experience of being asked to wait in a separate room from the other folks in the lobby. Like I had a person walk up to me and say like, "Hey, you're Austin, right? What are your pronouns?" First of all, please don't ask your patient pronoun questions in front of other people in a space where they might be like outed. Also, if I'm the only person in the lobby that you approach and say like, "Would you like to wait in a separate room?" That might be like generous if I am nervous to be in space with those folks, but also it's pretty isolating to be like alienated in that way and like been like, hey, you, the obviously different person, let's put you in the corner, right? So yeah, having increased transparency and increased like intentionality around all of those things can only help. But yeah, I think I'll leave it there. If folks have questions about any other experiences I've had in medical care, I am more than happy to share and fire away with any questions. Thanks so much.
Thank you so much, Austin. That was powerful to hear you speak and talk about your experiences. I do have a number of really great questions, and I'd like to direct them to our panelists. So the first question I think would be for either Dr. Bailey or Dr. Gore. A question from Dr. Vega for hormone setting, for hormone treatment and risk of stroke. So in the setting of an acute stroke, would you want to alter hormone therapy at that time, or is there any increased risk for acute stroke with any kind of hormone therapy?
So I can jump in and correct me if I get anything wrong, Dr. Gore. But so I think what they're referring to is that estrogen is in general a prothrombotic hormone, and so that's why women, cis women, have slightly higher risks of, you know, blood clots, pulmonary embolisms, and embolic strokes for that reason, and why we think about smoking and hormones in oral contraceptives and stuff and stroke risk and risk of pregnancy. So if somebody's going from like cis male levels of estrogen to now adding additional estrogen, they probably are increasing their, well, they are increasing their clot risk relative to what it was before, but up to the level of a cis woman, because the target ranges for hormones are the same as the physiologic hormonal levels in a cis woman. So slightly higher risk, obviously about half the population is walking around with that level of risk, and so it's not, you know, something detrimental. I highly doubt there's been a study to look at in an acute stroke in a trans woman if withholding estrogen has any effect, just because the N size of that situation is probably not very big. We don't routinely use estrogen blockers in cis women who've had a clot, you know, so it probably isn't necessary, but that hasn't been researched. But yeah, basically what I tell patients is you're gaining the risk of the gender or the sex that you weren't. So there is a slightly increased risk, but just to the level of a physiologic or cis female.
Wonderful, thank you. Hopefully that answers the question. I think that was very complete, and if there's any follow-up, please ask. So there were a couple of questions that kind of fell into this bucket, and I wanted to kind of consolidate them. So so the first part of it is, how do you respectfully, what's the respectful and what's the etiquette around asking people for their pronouns? So I know, Austin, you had mentioned definitely don't ask in a large group of people if there's there's always a concern about whether people are out or not. So don't ask in front of a large group of people. Are there other examples of etiquette around asking people for their pronouns? And is there really any situation where you would need to, and what would be the situation where you would need to ask someone, what is your sex at birth? And kind of what's the correct way to go about that, kind of for everybody on the line?
I can speak to the pronoun piece, and then when we get to the like ways that it might be a medical necessity to know a person's assigned sex, I'll pass it to the folks that are more qualified to speak on that. But I would say in terms of like decorum for asking for pronouns, normalizing just as a practice, asking for pronouns or sharing your own pronouns wholesale, not just when you're in the room with a trans person. So doing so in meetings, when you're meeting new people, doing so when you introduce yourself to a patient, you can share your pronouns, things like that, wearing pronoun pins, things like that, that assure the trans patients that, yeah, exactly, that you are not just doing that when you absolutely have to, but that it's something that you genuinely value. When it comes to asking for pronouns, yeah, sharing your own first, but also not robbing folks of the agency to say no, like I don't want to share my pronouns, because you can always just use a person's name. You don't have to use their, or you don't need their pronouns in order to speak to them, about them, things like that. I work in behavioral health, and so I will frequently say like I have a client, or I work with a kiddo that blah blah blah. There are all kinds of gender neutral terminologies that we can use to refer to folks that we're working with, that don't necessitate information about their identity. But if it's going to provide additional comfort to your client or your patient, you can say something like, if you ever feel comfortable sharing your pronouns, I'm open to hearing them. Or you can say, do you have preferred well, actually, the term preferred pronouns is a little bit dicey, because some people are like, they're not preferred, they are my pronouns. And when you say they're preferred, it means I chose this, right? Which is careful. So if you say like, what pronouns do you like, or what do you use? Mine are this. Those are appropriate. I would, again, just encourage folks to always do that in like a one-on-one setting or a small group setting, and never expect that folks are going to share their pronouns with you if they don't want to. But then I'll pass it over for the risk associated with not knowing a person's assigned sex.
Can you repeat the question? I'm happy to answer it. I've kind of gotten lost because I've started reading questions on my own.
Yes, of course. So there were a couple of questions that kind of fell into the same bucket, and the questions revolve around are there medical situations where it would be critical to know a person's sex at birth, and are there situations where it's really appropriate to ask? So, like for example, there are like sex-based calculations for labs, like lab values, and there are sex-based calculations for like pulmonary function tests. So are there situations where we would need to be, it would be critical to know the sex at birth? And if so, should we be, is there a good way to ask that that's respectful and understanding of people's identities?
So, okay, I'm not an expert here, but I'll just share with you my experience. I think there are absolutely times when it is important. I'll use the example of cancer screenings, for example, because I think even after patients transition medically, they still may have the internal organs that they were born with. And as one ages, it becomes important, as we do for, as Dr. Bailey said, the cisgender patients, we screen for various cancers. And if you have a particular organ in your body, we're going to want to screen for that. And I'm thinking specifically of a cervix for maybe trans males who haven't undergone a hysterectomy, or a prostate in trans females who haven't had a prostatectomy. So I think it is really important to ask. And one way, I guess the easiest way I do is when I do my initial consults on patients, I ask them, you know, or I just say, what was your sex assigned at birth? And they answer that, and I have that marked in their chart. There was a question on there about someone who said that they had a patient who didn't disclose that they were transgender, and then they got on the wrong thing. You know, I don't know really what to say about that. That's kind of an individual case basis, but I would anticipate that perhaps that's going to come up, and we just have to deal with those as one-offs. But I think not being afraid to ask the question, because when it comes to providing medical care, like, we're here to do the best for the health and welfare of our patients.
Can I add just two quick things to that? I think we do the same thing with everything else in medicine. We're already doing this, and it's easy to see like, oh, this is a new thing I'm learning, so this is an exceptional situation. But like, if I have a patient who broke his foot and I'm talking to orthopedics, I'm not saying this is my patient with erectile dysfunction and I think he broke his foot, because the orthopedist doesn't care. But if I'm talking to a cardiologist about cardiovascular prevention, that might be an important risk factor. And so I'm including that medical detail that I know because it's relevant to this situation. If we're treating something completely unrelated, then it's not relevant. So you include it when you need to. And it is important to know for those sex-based calculations, but it's also important to consider that maybe you want the number associated with the patient's gender. So a real common thing is when I'm prescribing hormones to a patient and I'm monitoring their hormones and I get the levels back, I may have a trans woman and the lab printout lists them as male, and so then it says their estrogen is off the charts, so their estradiol is way too high, but actually it's exactly right. It's in the physiologic range for the female value, which is what we're going for. And if I were to just look for the flag rather than the actual number, I'd say, oh, too high. And so it is important to pay attention to those things. And that's why it would be nice some point if all of our EMRs had sex and gender listed separately, or sex and gender identities, so you could know, you know, how to interpret certain things. Like I don't know what pulmonary function tests, which calculation you'd want to use. I haven't run into that.
Yeah, I like that point that you made, that a lot of times in medical care, it doesn't matter. We are all people, and not the sex that you were assigned at birth. It's just not relevant to who you are as a person or your medical care most of the time. I think some of the time when we feel like we need to ask that question, it is curiosity at play, rather than an actual true need to know based on providing the correct medical care. So just my 2 cents on that. There's two questions kind of along the same lines. One, they were about pediatrics or patients who are at the time of evaluation not able to speak for themselves. How can we, if the parents or the guardians are not supportive of the patient, how can we as care providers kind of navigate that road of advocating for the patient while, you know, being respectful for the caregivers? That's
Let
a
me
tough
jump
one.
in. I'll start with that one. I think the way that I approach that is to follow the lead of the patient. And that situation has come up multiple times for me in working with patients and their families or parents in particular. And I think there's not only out of respect for the patient, because the patient is my patient, but also in terms of modeling for parents to just provide them an opportunity to see them, to see their children referred to in a way that the child prefers to be referred to as. That's bad English, I apologize. But so my approach is usually just to follow the lead of the patient and work with parents. And oftentimes I'll have parents misgendering and misnaming their children right in the room with me. And we just kind of go with it. You know, I don't make a big thing. I'm not out to make anyone feel bad or correct anyone. And sometimes if they bring it up, sometimes parents will bring it up, and I will say and acknowledge again the empathy part, which is, yeah, it's hard. It's hard to go through this with your child. Sometimes the children or patients are much farther advanced in their thinking and what they want to do and what their expectations are, and parents are kind of the last to find out, and we're bringing them along. So I try to also really empathize with the parents in front of the children, to show them and really validate that this can be a really hard initial process to start out with, but that in the end, what we really want to do is take care of the young person. And as I said before, you know, what they want is to be referred to as the name they want. So to the best of our ability, following through with that.
Do we know if are there any kind of like legal forms that people can fill out, or anything that would indicate their wishes in case, you know, something happens? Like we have a post form or a DNR form that people can carry with them. So if there's something that happens and they're unconscious or not able to speak for themselves, do we have forms like that available that we can get at the hospital, or have you seen anything like that out there? Just in case their family is not.
Yeah, no, that's a great question. I'm not familiar with an actual form like that you're talking about. I know that we certainly have conversations I do with patients with regards to legal name change or getting their names changed as soon as they're able. It's not necessarily an easy process, and sometimes comes with a cost added. So that can be a barrier, unfortunately, to patients. There are, you know, what patients start to look for is they start to want to change their gender and name on things like birth certificates and driver's license and social security cards, all of which have step process, which they have to go through. And yep, thank you. And so that if they can get their names changed on their, you know, legal identity cards, that's probably the best way. I think the other thing for those, you know, within our system, we use Epic as a form of electronic medical records. And there was another question in the chat about this as well. But when it comes to medical records, we were able to finagle Epic to come up with not only their legal name, because I think as noted here, sometimes we have to keep by medical records their legal name, but right underneath that in quotation marks, we have their preferred name. So it's really front and center. As soon as you open their chart, you see the legal name, and then right there is the preferred name. So I can imagine if my patient showed up at Sacred Heart Medical Center, they pull up Epic and they would see that exact same thing. So that would be another way, you know, if someone were to be identified, but not any specific form. Maybe there could be a medical alert band, but I'm not familiar with that.
That's great information. Thank you. I think, so we're approaching time, and there are just wonderful questions popping up on the chat. So what I might do is we will go ahead and close out now, but I will take down these questions, and then we'll do, Elizabeth had the idea of doing like a frequently asked question addition to the video when we post it on our website. So, all right. I want to thank our presenters just with all my heart. Thank you so much for agreeing to participate and really being engaged and willing to speak with us about this very important topic. I also want to, in closing, announce that we will be having a book club, a diversity book club, and we have chosen our first book. It's called The Immortal Life of Henrietta Lacks. It came out in 2009, so many people may have already read it. I felt like it was and Elizabeth felt like it was a really good kind of introduction to this type of book club. We'll be having the first meeting on August 9th at 12 p.m., so that gives people plenty of time to read the book. It's a little bit dense and long, but it is extremely engaging. And if you can't get the book done, there is a movie with Oprah Winfrey. So it's that's another option if you can't get through the entire book. But hopefully people can join us for that. It will be, I believe, in person and WebEx.
Yep, so we're pretty excited about that. It is part of this inclusive care series, but we thought we would change up kind of the format so that we have kind of a mix of lecture and panelists and then this kind of more book club style discussion. So really looking forward to this first one. And we've had a little tiny book club at Kootenai Health in the past on this book, and it was really, really fun. And we all learned a lot and had really great conversations. So I'm really looking forward to seeing that expand. So for those of you that are interested in receiving continuing education credit, just note that I will be pulling the attendance out of WebEx, and I will send you all an email with a certificate that indicates that you attended the program and the number of hours. We do write for nursing education and medical education credit specifically, but if your particular organization will take cross-disciplinary credits, you will have a certificate that you can share. And then for our physicians and APPs, we do have just a short evaluation form that's required to be able to offer those credits. So I will send you a copy of that form as well. As always, we will post a copy of this presentation once it's rendered and downloaded onto my computer, and we'll get that up onto our cloud page, and we'll include the FAQ so we can get all these questions answered as well. And with Dr. Peterson, I just echo thank you so much for our wonderful panelists. You guys were amazing, and we really, really appreciate everything that you did and shared with us today. If there are any other questions, please feel free to reach out to me or Dr. Peterson, and we'll help you out. Thank you so much, everyone.